Sure. I'm so excited to have you here.
Glad to be here. I'm guessing we're loud enough. What? There you go. Good guess. Perfect. All right. We got to record them.
Yeah.
All right.
We need to hear you. We need more.
This will be for the karaoke, which we will not do. So the discussion here today, kind of the debate topic was the future of healthcare. We'll turn it into that, but we thought maybe telling a story about kind of where we've been with one of our endeavors might be great framework for teeing up kind of the future and where we see these things going. So let's make this interactive. Ask questions as you would like, and we'll go from there. So I feel like I need to do the Fresh Prince of Bel-Air thing, the story, but I don't know why. It wouldn't be good. So we're going to talk about kind of what we learned in the ideation and creation, and then from a Holmes-Murphy perspective, divestiture of Simplepay Health, and an attempt to bring something to life that we thought could reinvent the experience for both providers and for patients was kind of the goal that's there. And Simplepay really was the brainchild of Scott Chamberlain. And for those of you who know who Scott is, Scott was the founder of Compass, so the navigation company. So Scott founded that company, and in ACAP, Wally leading ACAP for Holmes-Murphy at the time, majority of the distribution for Compass came through ACAP and Wally. So when Compass sold, they sold to Alight. When they sold to Alight on the day after that transaction, Scott left, joined us to start Simplepay. And his thought with Simplepay was to take everything he had learned while running a navigation company and try to bake it all into one put-together model so that the parts connected better and could work better for the patient. That was really his vision in terms of kind of what the thought and ideation behind Simplepay was. Wally, you were outrageously close. It was you and Scott that started that. Any kind of opening comments on the founding?
Yeah, I think I would tell you that when Scott was leading Compass, on a good day, we might be getting a single-digit level of engagement. And, Scott, as being really one of the foremost leaders in the industry, and how do you take big data, put it all together to identify where there's opportunities, Scott was burdened by, and then we became burdened by, the understanding that we can connect patients with better quality care, but we could never get them to be engaged enough to a level to get there. And as we talk more about what we've learned along the way, we realized that we had to remove insurance complexity if we really wanted to be able to be able to get patients to be better in consumers, which is a word that we use a lot, and we'll talk a little bit later about why we don't call them consumers. So.
Yeah, so like any good book, if we flip to the last chapter, so where we are today, just kind of clarify where that is. Holmes-Murphy started Simplepay as part of ACAP in there. We transacted that last fall, and so Blue Cross Blue, an entity that is owned by Blue Cross Blue Shield of Minnesota, is actually now the owner of that business. Wally went with that business to run that business for Blue Cross Blue Shield of Minnesota. So that's kind of where all of this sits today. So the challenge is that, there we go. So the problems we were trying to solve, same problems that all of us are trying to solve all the time. Some of you have seen my cartoons before. We'll keep these cartoons going until we solve these problems. They'll be around a while. So the first is what I refer to as the health Costquito. That is not a lunch buffet item at Pancho's Mexican food. The Costquito, and I use that as an example because the mosquito is actually the deadliest animal in the world. More people die from mosquito bites than any other animal if we're excluding humans ourselves from that mix. So, but mosquitoes are all around, right? They're a nuisance. and you kind of look at them that way, but you actually realize they're not just a nuisance, they're actually a very big danger in many parts of the world. Healthcare costs we view as a nuisance, right? It's pain, and I don't want to pay that much deductible, and that was a surprise bill, those kinds of things. What those of us that are in this room, because of what we do understand, and some in our economy don't understand, is that health debt is the most common factor in personal bankruptcy. So this out of pocket, these expenses, these kinds of things, yeah, they're a nuisance, but for many families, they're financially dead. We as an industry need to be aware of that and actively trying to solve that. So part of Simplepay was trying to creatively get to that. The second problem was that I couldn't get the clicker to go. And then after that, once I got that, is healthcare is outrageously confusing. Wally, you want to talk a little bit about how confusing it is?
Yeah, so, one of the studies that was a big influencing point, part of our why in designing, a simpler model of insurance, was a study called the Global Brand Simplicity Index. Everybody in Holmes Murphy will be super familiar with that. And basically what that study shows is it ranks from the very simplest to the most complicated industries, on the planet. In the United States, where do you think, on a list of 1 through 25, where do you think health insurance ranks? What number? 25. 25, right? We rank dead last. If you click one more slide, and none of it's going to be a surprise to any of us in the room, right? If you think about, the patient experience, it's pretty messy, right? They've got plan design terms that they generally don't understand. Part of the studies that we've been reading shows that if you give claim participants 4 basic insurance terms, deductible, co-insurance, copay, and out-of-pocket maximum, put the terms in one column, and you put the definitions in another column, and you ask them to match it up. What percent can match the term to the definition accurately? What percent? All 4? 50%. 50%?
10.
10? I wish it was 10. It's 4%. Only 4% of plan participants, if you give them the terms, they can match the term to the definition, right? 36% of millennials, 36%.
But if we put that communication in a video rather than paper, they get it right.
Oh, yeah, that's right. You got to put it in paper. That's right. Remember to in a video. And the problem is we all go to our open enrollment meetings, we nod our head and we shake like we understand. We don't understand, right? Scott used to tell us that when members would call Compass and call their concierge health pro, they would not say co-insurance. A lot of times they would say coin insurance because they think it has something to do with money. Like, if there's any good news in any of that, it's that we don't use insurance often enough to get good at it. So we take some positive out of it. But, think about our industry, right? It's one of the few places where individuals will never know their cost ahead of time. They don't have good line of sight on quality. And then think about all that paperwork that you have to spread across your kitchen table when all the bills and EOBs come in that we just get for months and months and months. And obviously we wanted to make all that go away. I guess my final comment is think about all of that in the backdrop that as Americans, we are great at being consumers of anything if we have the information and if the model is simpler. So that's a little bit of the why behind Simplepay.
Oh,
Is this one you?
No,
Looks like.
we'll come back to that.
So what is Coop Health? I'll go there.
All right, so we'll start there. So obviously we launched Simplepay, initially as a program, that we wanted to get some proof of concept. We'll talk a little bit about the story that led us towards making it available now on a national level with Aetna on the Meritain platform. And if you see the logo Simplepay, just know that is effectively an Aetna insurance product, a new alternative health plan. If you see the logo Coop, C-O-U-P-E, like a car, that just means that's the same version of the program, but on a Blue Cross network. And we'll talk a little bit about why getting a new disruptive model of insurance connected into insurance carriers like Blue Cross and Aetna are really necessary if we're going to have a chance to actually transform the system. And we'll cover a little bit about that. I'll come back to this slide and we'll talk about how we have tried to solve for complexity.
So problem number 3 is the quality of care that we receive in this country, which, as all of us know it's not very good. That doesn't mean we don't have great doctors. It doesn't mean we don't have great hospitals. It doesn't mean we don't have great medicines and great technology. We have all of those things, and yet, consistently, when we compare to other economically developed countries, the outcomes, how healthy are we when we need to encounter the system in this country, we continue to finish last or near the last in every survey. There was one study from the Commonwealth Fund, and this one really floored me, that if you compared, if somebody was diagnosed, if somebody had some kind of condition, that there was a treatment, right? So you came down with something, there's something that the healthcare system can do. You can take a medicine, you can have a procedure, you can do something about it. So those things that we have, at what rate do people in the United States die from things that we could have treated compared to other countries? So it's not how healthy are we or not, but just when somebody got sick, did the system work when there was a cure? People in the United States die at a 58% higher rate from things that we can cure. Last in that. And why is that? So what I've heard, and this was actually the cover to my book that nobody other than my mom read because it came out the month before COVID. She liked it. So if you think about it, it's what I call the T-Rex effect. And part of Simplepay was to solve this T-Rex effect. Part of what all of us need to do every day is solve the T-Rex effect. So the T-Rex effect, what is that? So if you've got a T-Rex, what's the defining physical characteristic of a T-Rex?
Little arms, T-Rex arms, right?
The T-Rex arms. And so in my imagination on this, assume that this right here is an easy button to survive. All a T-Rex has to do is go up, push that button, and whatever is ailing the T-Rex, they're cured. Except T-Rexes have all died. Why? Because they had these little arms. And so all they had to do was reach that button, but they can't get to it, right? That's healthcare in America. The care's available. It's right there. We have more hospitals. We have the doctors. We have the medicines. And yet, for some reason, people keep dying at a 58% faster rate here than in other countries. Because for whatever reason, that care sits just out of reach for far too many people. Our job in our industry is to connect those people with the care that they need. We need to all be thinking about that every day, and every decision we make either builds a ramp and makes it easier for people to get to the care they need, or we build a hurdle. And a fundamental of insurance design is every decision we need to be making should be building ramps to get people to the highest quality care, not hurdles that try to keep them from getting to the care they need. We've got to own that and solve that. So you cannot forget this illustration because it's like painfully awkward. So that's there. So part of Simplepay was to make it easier for people to get to the highest quality care and make it harder for people to get to low quality care.
And I know we'll talk some more about quality, but I'll say as a guy that's been in the industry for 30 years on the hospital side, the insurance carrier side, the consultant side, measuring quality is not new, but I think we have to get real about what are the things that actually make a difference when we're measuring quality. High-performing networks that tier providers and reduce choice actually works, the opposite of how they should work. And we have to think about healthcare like a team sport. Going to a top-quality doctor does not produce a better result if we don't get downstream referrals and admission patterns that also perform well. And, any hospital executive will tell you that there are some things they're great at, some things they're okay at, and some things that they actually take their family somewhere else. There's no such thing as a hospital being great at everything. And so we have to sort of throw out the old playbook of these high-performing network models and start thinking about how do we identify quality in our community. And we want all the providers in the network, and we want to be able to get patients aligned for their clinical situation with the provider that delivers the best result. And when we do, the impact to outcomes is tremendous, and it obviously reduces overall spend.
So, was all the snake oil?
Well, I'll tell you, it wasn't until, the last couple of years where we had our thesis for, can we measure quality? Yes. Can we get patients to engage with better quality providers at a rate that's going to move the needle? And, I would say a few years ago, we were hopeful. We had a thesis that the answer would be yes. Today, we have measurable results that are they're so consistent. And I'll put up some numbers on the screen that I think will encourage us that when we think about the future of healthcare, I don't think we have everything dialed in yet. We don't have everything operationally working and the technology working how it needs to be, but we have results that have encouraged us beyond where we thought we could. So,
We would dive in here, and we keep rolling somewhere else. This is fluid.
Yeah, this is fluid. No, I think we'll go. Let's go back to the line chart. Let's go back to the line chart. That'll be a good launching point. So one more there. There we go. So we talk about Simplepay. Let me just kind of give you an overview on what's the patient experience. What's the patient experience? First thing we realized, think about insurance plan design literacy is just atrocious. I don't need to have a deductible to buy a consumer product. Why do we have to have deductibles in healthcare? So we got rid of that. No deductibles, no coinsurance. The patient has a price tag for every covered medical and pharmacy service, just like when you buy anything else in the real world. You go to have a physician office visit, it's one price and it doesn't change. You have a hospital stay, it is one price and it doesn't change. I'll tell you, it's a copay, we just don't call them copays, we call them Simplepay amounts. And we combine it with information on quality. You set a lower price for a higher quality provider, right? Just like how we would buy anything else in the real world. I would tell you that we thought that was going to be enough. You have information on price, you have information on quality, you can be an empowered patient, and it wasn't. Because the other thing that was happening is that individuals were getting buried with many bills and ELBs, and they could never translate, hey, you told me this is my price, but I don't know who to pay what to who. So we had to get rid of all of that. So in this model, patients never pay a doctor, a hospital, or pharmacy ever again. They show their Aetna ID card, they go have their services, the providers are paid their contracted rate in the network in full, and patients never have to pay doctors, hospitals, or pharmacies, and hospitals and doctors never have to collect patient responsibility ever again. How do you think they feel about that? They're out of the billing collection and bad debt space. And what does the patient get? One simple monthly statement. And the price on that statement will match the price you saw earlier. Like I want to go ahead and admit, when we designed Simplepay, we didn't invent anything. We just made health insurance as closely as possible resemble the way that it works when you buy anything else in life. But the price tags will always be lower, and you go not to a cheaper provider, you go to a higher quality provider. The old days of thinking that lower cost providers on a contracted rate produces lower spend is actually misplaced. We started there with Compass, but what we realized is it's about getting to better quality, better efficiency, better outcomes, and you have to have a contracted rate that isn't too far out of range, and that's really what produces the better results. So that's a little bit of the ground setting.
Any questions before we dive into a little bit on the quality items? Yes, sir.
How are you? I get I think it's Brecker report where they rate hospitals as well as they just enlighten me. I think less than 2% of the hospitals are complying with the transparency. So how are you guys putting the prices together? Unless we're just excluding Baylor and, well, no, according to the report, it's like you'd have to exclude 95% of the hospital. So how are you doing it?
So in our mission to try to, leave the campground a little cleaner than when we got there and actually change, the complexity and the affordability challenges for our industry, we're trying to socialize a new term and move away from the term price transparency, which we've been at price transparency for 20 years, and move to a model that's price certainty. So the patient doesn't really care what the contracted rate is between the providers in the network and the insurance carrier. They could care less. Just like when we go to a retailer and we buy a service, a product, we don't care what it costs for the retailer to put that product in inventory. What do we care about? What does it cost me? It's human behavior. So we just disconnected the patient responsibility. We disconnected it from the actual contracted rates because, as much as I'm a fan of those transparency rules, and I hope we keep making progress, we're moving away from price transparency. The word we'd ask you to think about is a price certainty strategy, a price certainty. The patient has certainty in what their cost is for every covered medical and pharmacy service.
So Wally, that question was on measurement of quality.
Was that on measurement of quality or the
Yeah,
price?
which hospitals how do you choose?
They seem like Baylor, Plano is, according to them, one of the best heart hospitals,
Yeah.
but pretty bad in some other areas. So.
Yeah, so Scott's work when he was leading Compass, was to develop one of the country's largest claiming quality data sets. Today that's data on 130 million patients, which what really matters from that is that when we look at patients and measure all of the different data points that are measured independently, you can see that patients that go into higher quality providers in general are expending about $5,000 in lower cost per patient per year. And, we still need to draw from some of the industry studies, but I think we've moved to a place of using an independent data set and not necessarily go back to things like leapfrog, which, aren't really granular enough.
So you have the transparency on the pharma side as well, not transparency.
Yeah.
Versus,
So pharmacy is easy. Pharmacy is a unit cost play. So like I'm not going to tell anything that's that big of a secret. It's cheaper when the drug gets filled at Walmart or Costco because the contracted rates are better there than it is at Walgreens. Just the way that hospital or pharmacy pricing works. So in this model, the patient's simple pay amount is less if they fill their medication at a place where we have better contracted prices, and then all the AWP spread goes straight to the plan sponsor.
So Wally, your national network partner is Aetna, that is owned by CVS. So how does the pharmacy piece work in terms of that?
CVS is not tier one. They're not the low cost efficient pharmacy. So we are setting the copays to be lower if you go to places where we have better quality, better efficiency, better rates in the pharmacy side. When you go to Kroger, it costs a lot less to fill that drug at $200 than the contracted rate at Walgreens or CVS at $400.
So is Simplepay like my GoodRx app? I don't get it. So if I pull up GoodRx and I have my pill, then I know what GoodRx is going to tell me at each of the pharmacies. Is Simplepay going to based off that GoodRx price? Because the problem with pills is we don't know how much they cost.
And we don't want them to know how much it costs anymore. We just want them to know.
But the plan wants to know how much they cost.
Yeah, so within Simplepay, the participant knows exactly what they will pay for that bill. GoodRx knows the same thing. So Mark Cuban has just launched his pharmacy. Everybody aware of that? So I was on a call with their leadership this morning and kind of learning about that. They're going down that same path of saying, and so what I can't remember the name of it. I mean, the name of it is like the Mark Cuban something pharmacy. So what they're trying to do is the same thing. So where Mark Cuban's company is going is they will buy the drugs. They will then sell that drug at their cost plus a known, I think it's $3 dispensing fee plus and it's cost plus is the name of it. Cost plus, thank you. And so they're moving into that space. I think we will see more and more and more in pharmacy get away from, hopefully, the opaque nature of what has been there. The difference between GoodRx and something like Mark Cuban's Cost Plus program and then the PBM, GoodRx is a discount program. So they've negotiated a discount from there. That can work in some places. Mark Cuban's Cost Plus, I think all of us will be looking at that kind of approach in the next year or two as it comes to market. It's generics only now. They're going to add brand name drugs to that. Those kinds of things will come into play. And their hope, Mark Cuban's hope, is that it forces transparency and known prices at a patient level. So the Simplepay program is getting there in a different way, using some PBMs behind the scenes, but there's more and more and more coming in the pharmacy space. All right, let me roll forward. I found that interesting. You know, stay here. You want me to roll to?
We'll come back.
Okay. I already did that. All right, so let me talk about this quality issue that the gentleman asked, really about quality, and I'll put it in terms of Hunger Games. So if you think about the game that we're going to play, let's say that you or a loved one has excruciating back pain, can't move, can't get out of bed, not sure what to do. And in our Hunger Games example here, somebody's going to shoot a free throw. If they make it, you're better. If they miss, use the Texas term, you're screwed. Your back hurts forever. Like you're done. Might even get worse. All right? So somebody's going to shoot that free throw for you. Who's going to shoot your free throw?
Best doctor I'm fine.
You're going to have a doctor shoot your free throw?
Oh,
Dr. J, maybe. So if somebody's going to shoot a free throw, you want to find somebody who's good at it. I mean, that would help, not just a random person walking down the street. You probably wouldn't want me shooting that free throw as a tennis player. That would be a bad idea. So you get there. Healthcare is the same way. So, but in our Hunger Games example, we can tap it. Yeah, there we go. All right, I give you three choices. So the three choices, first you want somebody who's licensed in basketball, right? A professional basketball player, not just anybody to do that. You want a Dr. Death scenario come here. So I give you three choices. Tiffany Mitchell, she plays for Indiana. That's where Hoosiers was filmed. Good basketball state. LeBron James, probably the best known basketball player on the planet. Or Kia Nurse, and I chose her because her name sounds really medical. So which of the three, if you could have any of these three shoot your free throw, who would you have? I'm hearing LeBron, I'm hearing Kia on that.
What were the best free throw percentage?
The best. So how would you know who the best free throw shooter was? You go to ESPN.com and look. Right, it's not hard to figure out who makes the most free throws. That data is readily available. It's there. Healthcare is really not that different, except you have to have data scientists behind the scenes put it together. Somebody that's freakish like Scott Shainvogel, who started Compass, or there are other options out there. Somebody to sort through the data and say, okay, who makes it more and who misses more? And that is, I'll just come over here and do it. There you go. Perfect. Thank you.
Oh, double tap.
If you look at, go back.
How do I go back?
I don't know.
Left button.
There you go.
There we go. Okay, so
Got it.
if we look at this, and this is a year old in the data on there, LeBron misses 3 out of every 10. So if 10 of you chose him to shoot your free throw to relieve your back pain, 3 of you may never walk again. 7 of you did great. Kia Nurse, 86. It's around the average for the WNBA. But last year, the best free throw shooter on the planet was actually Tiffany Mitchell. 95.1% free throw. And just so you know, WNBA players make a higher percentage of their free throws than NBA players. So I want a female shooting that free throw. And I want Tiffany Mitchell because she makes it the most often. And if need be, I might get on a plane and fly to Indianapolis to just be there. You know, I might do a little medical tourism on this. All right, so go to the next slide. So if you think of healthcare, or think of this, it's not the team. I wouldn't say, oh, well, just give me anybody on the Indiana Fever. Well, that's really not that great. Or, as an example, the best free throw shooting team was the Phoenix Mercury. The worst free throw shooting team was the Connecticut Sun. That's how we look at healthcare. Oh, what hospital they practice in? They're part of what group? We don't know individual shooters' names, but we know the team they play for. They play for Baylor. They play for THR. They play for... And so the problem is that if you're just picking the team, the facility, you're going to miss out, and you're going to end up with failed surgeries far too often. So I could pick somebody from the Connecticut Sun that's in white in this. They actually had 2 individual players that were in the top 10 in free throw percentage in the WNBA. As a team, they weren't that great, but they had some great. We find that in the clinical data. It's not, did I go to Baylor? It's not, did I go to Presbyterian, or did I go to this? It's which doctor did I see for which procedure? And the facility is actually less important. It's really about that team that you choose. That's part of what Scott discovered at Compass that he came to start Simplepay. That same thing exists in things beyond just Simplepay. But that, I think, is the next frontier as we start to get to this data. We'll go one more forward. Thank you. So that was free throw shooting, right? Had nothing to do with medicine. This is data on surgical infections after colon surgery in Dallas. So here are the teams. Don't those percentages look really similar to the free throw percentages? It's almost identical. And then you look at the doctors and go, again, Texas vernacular, holy crap! If you look at this, the infection rates after colon surgery by doctor are there. So if you have to have colon surgery, my guess is it doesn't matter to you which doctor you see because they're all surgeons, right? It's awesome. Is that how you feel? No, your infection rate it's just like the free throw error rate. Why would I be putting myself in the position to increase the likelihood of having an infection after the surgery? Would I not want to put myself or somebody I cared about or employees I cared about or clients I cared about, wouldn't I want them to get to the place where the likelihood of error was the lowest, the highest success rate? And that is really what's behind Simplepay. It's what's behind some others. The top doctors, if we can get people to the top doctor, almost without regard to which facility, costs go down, quality goes up. Jennifer.
Well, that's what I was going to say. It looks like if those colors matter, then the top doctors are primarily not even at the top facilities that are there.
And so what this did, the green is all other facilities in Dallas in this data. And so these were the most common facilities. But yeah, it's
aren't even at your...
There were three that weren't at any of those
So
four.
that kind of blows up the thought of, well, I've got to get into Baylor. No offense, Baylor, we want your money, sponsor our events, or vice versa, right?
It's the doctor, not the hospital, that matters the most. It's getting to the right team.
And then, so capitalize on that for me, please. So I go and I find my doctor through whatever service I'm using. There are all those other fees associated with it. So are the doctors in network? Is everyone in network? Does Simplepay have a network? I'm so confused.
Trying to decide whether to flip to some slides towards the back to give a visual. In fact, I'm going to do that because I think I'm creating confusion in the room without. Let's go a couple more slides. One more. We're going to come back. Okay. So, has anyone ever done any online shopping? So, if you're buying a flat screen TV, what are the two pieces of data you need to know? You know, quality, reviews, maybe you go to Consumer Reports, you go and you want to know what the price is. Like this is what we've turned health insurance into. So you can go wherever you want to go in the national Aetna network. In some markets, we're with Blue Cross. But think about this on a national level with Aetna. And it's your choice to go wherever you want to go. But we're empowering the patient with 2 pieces of data they should have had years ago around quality and around price. If we go to the next slide, nobody has to go to open enrollment to know that 5 stars is better than 3 stars, right? We know that as Americans. We give the patient credible information drawn from the universe of available data so that anybody, you don't have to go to medical school, can easily see differences between quality and from provider to provider. If we go to the next slide. The key here is that we've moved away from deductibles and coinsurance and the many bills or EOBs by giving every single covered medical and pharmacy service a copay. So if I was having medically necessary outpatient knee surgery, I have one copay that is going to cover everything that happens from when I walk in the door until I walk out the door. That's going to cover the hospital, the surgeon, the anesthesiologist, even if they're out of network. Your copay is your copay is your copay. Now, we have indexed those copays to be lower, not only when you go to higher quality hospitals for that service that are combined with higher quality surgeons, but also the hospitals that don't have a lot of out-of-network anesthesiology. So that copay is already covered and has been indexed to deal with the many services. You know, for your knee surgery, exactly what your cost is, and it doesn't change. You have price certainty.
So when you say copay, that leads me to think that this does not apply to high deductible health plans. High deductible health plans do not have copays.
Yeah. So we offer 2 versions of the model, one that is a qualified model, one's a non-qualified model. So if you go to the next slide, and we're going to just finish off the 3 steps. No, I'm grateful for the questions. So when you go to the provider, we covered this earlier, it says on the ID card, no patient responsibility is owed at the time of service, that the plan pays the full contracted rate. So you show your ID card, providers verify benefits, they're paid in full. In my knee surgery example, the surgeon gets their Aetna contracted rate, the hospital gets their Aetna contracted rate. If you go to the next slide, please, then the individual just gets 1 monthly statement. And the key here is the price on that statement will always match the price they saw earlier. They'll always match the price they saw earlier. Now, I'll go ahead and tell you that one of the big challenges we also know that is happening around us is that for many Americans, when they get their monthly statement or their many bills and EOBs, they don't have the money to be able to pay for it. So when you get your monthly statement, it works like any other bank statement. Pay in full. We actually provide them a 1.5% credit on their next monthly statement if they pay in full, or you can pay the minimum amount due, revolve the balance out over time at 0% interest rate financing. So embedded in the insurance model now is 0% financing. Then we'll talk about the reasons why that matters in the country. But individuals no longer have to scramble with high interest rate credit cards and payday loans. They get 1 monthly statement. They can pay it out over time. It never causes the employer or the plan sponsor to take any cash flow or collection risk. We're just removing providers from doing that collecting, and we're letting patients, we're bundling it into the insurance plan. So you know your price, you know your quality, no more bills or EOBs ever again. 1 monthly statement, 0% financing. Again, it should feel pretty natural because it's the way we tend to buy other things in the real world. Yes, ma'am.
So I presented a similar model to a provider group on this, and they turned it down because they said, what are you going to do to manage the cost outside of quality? In other words, medical management. Because just because I can go to the best quality person to get this knee surgery, did I really need that knee surgery?
Yeah.
So what's the rest of the story?
Yeah, so the question on that is really what about medical management? And so this will be a non-COOP health. This will be a Den Bishop response. As I said earlier, I now have 0 to do with COOP health or with Simplepay. I'll borrow the German term intervener. So it sounds German to me. So when people start on the wrong path, right? They start with the wrong doctor, wrong facility. They start, and all of a sudden, the diagnosis is wrong, something, just the wrong path. We, in the health insurance space, do an awful lot to try to get them course corrected. So that's why you have pre-certification, pre-authorization, second opinion, all these things that we do to go, oh no, this was happening, inappropriate or whatever it was, wrong. And it's all kind of third party, right? I mean, it should be between a patient and a provider, the doctor and the patient. And yet here we're trying to get insurance to intervene to get them course corrected. I think the big aha for me in all of this, whether it's Simplepay or other ways to go about things, if we can get people to the doctors that get it right more often, maybe we don't have to do all of this stuff that people hate. And they hate it. Doctors hate it. Patients don't like it. If a person has chosen that doctor and insurance is coming in and telling them to go choose someone else after they've voted, how well does that go? Not. We've decreased their confidence. We're just making it work. So I think the most innovative approaches, Simplepay being one of them, is using the data and finding creative ways to get somebody to go through the right front door and then let the system be that. So if we know that people are going to doctors that get better results, what if from an insurance perspective, we left those doctors alone and just said, go do what you do because you do it right, and trusted those doctors?
So in the Simplepay model, you cannot be a tier 1-ologist if you don't have admitting privileges to a tier 1 hospital service line. If we can just get the patient started with the best doctor, who we already know refers and admits downstream to the best, you can kind of get out of the way and let the best providers practice medicine and patients focus on their health. So we have dramatically de-emphasized the traditional pre-certification process. Instead, we're using those same clinical resources to get patients connected with high-quality providers, not once the pre-certification's coming in. If that's when we get it, it's too late. They've already established a relationship. You have to catch the patient when they're up at night, they're scared, they don't know where to go. You have a care manager reaches out and engages them, schedules the appointment for a tier 1 provider, and then you can kind of get medical necessity and all those hoops out of the way.
So Wally, you said facility and service line. What do you mean by that?
So every hospital system in our model is tier 1, they're also tier 2, and they're also tier 3. So hospital A may be tier 1 for cardiology, tier 2 for orthopedics, and tier 3 for oncology. Hospital across the street is tier 1 for obstetrics. So we're no longer narrowing networks. We're recognizing where the best doctors, where's the best hospital service lines. We're matching that up together with technology. So if the patient needs an ectomy, here's your best options that are tier 1. Go where you want to go. It's your choice. And when you go there, you're going to have one copay and no more.
Regardless of the service, right? One copay for the service.
The copays are door to door. Walk in the door to a doctor's office. Whatever they do for you, they do in-office lab testing, they do in-office EKG. One copay covers that door to door.
The bundle payment model.
It's basically a 3-tier copay plan to an out-of-pocket maximum. That's your plan.
At a patient level, it's a bundle payment. From a provider level, it's not.
Patient bundles. That's right.
Question.
Okay, my question is, I mean, I know from a patient standpoint, this is very simple, very, and quality and all that great stuff. What I want to know is, what are you doing on the back end? They're talking about networks and out of network, all this crap that goes on with, this is the price, and we're going to give you this discount where it really costs us this. So that's, I mean, what are you doing in that area?
Okay.
Yeah, well, what are you doing?
All right, so let's see if I can I back up? Can I back up here? Where do I go back? There we go. One more. Here we go. Okay. So this is the Aetna network. What tier is the Aetna network? It's tier 1, it's tier 2, it's tier 3. It's go wherever you want to go in the national Aetna network.
And if you're in Minnesota, it's Blue Cross.
It's
tier 1, 2.
It's it's the Blue Card PPO network on a national level. And we're not narrowing networks because the one hospital may be tier 1 for certain clinical procedures, tier 2 for another. All the patient needs to know is I'm having an ectomy. Is my doctor in my location tier 1, 2, or 3, and that's my copay. But the underlying network is the existing Blue Cross or Aetna networks. That's it. We're using same fee schedule, same everything. Unlike traditional quality management models in the industry where providers are paid differently, whether they're, high quality, low quality, or how they perform, in this model, your Aetna network contracted rate, if you're a provider, is your Aetna contracted rate. The only difference is they're paid that contracted rate in full. And we're empowering the patient to go wherever they want to go. What we see in that bar chart I showed earlier is we see that when we put this strategy in place, it's a plan design strategy is all it is. It's an Aetna product. It's a Blue Cross product. What we see is that the shift from tier 1 goes from the high teens the year before you implement that plan design strategy. It goes to 70 to 80% every single time in the first year. Individuals are voluntarily taking information, and we're not shaming them, we're not steering them, we're saying go wherever you want to go, and about 7 or 8 times out of 10, that's where they go. I'll tell you, the engagement rates actually stressed our business. We didn't expect them to be that high, and it put a little bit of pressure on our operating model, but we're now seeing that shift to tier 1 is fantastic. And look, it's math after that. If you shift to tier 1, you save about $5,000 per patient per year for the plan sponsor.
So what is the plan sponsor? What does it cost for the plan sponsor?
Their admin fee that they would pay to Blue Cross
And where are you getting that savings? Negotiating
So
fees, or is it,
So the savings come from when we go to higher quality providers that practice care more efficiently. We have a measure called the Goldilocks effect. So they practice more efficiently. They're not wasteful. They also don't underutilize where things get missed. There's an amount of care that's just right. They have better outcomes, fewer readmissions, fewer infection rates. When patients go to those providers in tier 1, just think of it this way. It's like ringing the cash register for the employer, $5,000 per patient per year.
And we've studied this beyond just Simplepay. The savings come from the errors that don't occur. So that was Scott Schneebogel's belief from the start, was that you don't have to go negotiate a network. You don't have to let the networks be the networks and negotiate that. You can take that which they have and make it work better. Can optimize that performance of that. So the real savings, we've seen it in Simplepay. Average cost reduction in Simplepay was,
I think this for 2021 is about 17% plan sponsor reduction with no cost shift to the employee whatsoever. In fact, because we're shrinking the pie, not only did employers see a 17% reduction, employee average out of pocket was also 17% less because they're now having a lower copay when they go to a higher.
And top tier utilization increased by what percentage?
So it went from about 18%. It jumped to 72% for our book of business.
So the savings came from moving people, again, think the free throw chart. The savings came because where 18% of the people were in the top tier, that's who they picked as their shooter. After the incentives, the education, those things, 72% of the people went to the best shooters, and the cost went down 72%. Or 17, let me correct, 17. Again.
And that's medical and pharmacy.
So I want to move us off Simplepay, because the discussion, this is one way to get here. It's the way that Wally's running. He's running this business. And it's a really cool way. But our challenge as an industry is not, is this the one answer to the one mousetrap? Our challenge is these problems that we have. People don't understand the plan designs. They can't afford, they don't know where to go. I mean, the Disneyland network, that's every doctor, because in this state, if a doctor says they want in the network and they're credentialed, they're in the network. And so we've got to figure out how to do that. We started this thing all wrong in terms of the way that we set this up. And it cost us significantly to get to that. So when I talk about infinite games and finite games, so if you haven't read it, Simon Sinek's book, The Infinite Game, is awesome. Read it. What Simon Sinek's book does, talks about a room like this, that you actually work with your worthy rivals to try to heal your industry, to try to heal big problems. And that's really what it's about. Healthcare, unfortunately, is also full of people who are playing finite games. There is a winner and a distinct loser, and they will do whatever it takes to do that. We started off with a mindset of being a disruptor. That was a massive, massive mistake. Healthcare is in the last data that came out, healthcare was 19.7% of GDP in the United States. It means 1 out of every $5 in America is healthcare. When you try to disrupt that and you go in guns a-blazing and you're Wally, Den, and Scott, you're going to get shot left by the side of the road. So that's what happened. We went in guns, here's how to make this work better. It was originally built with a third-party administrator and Cigna's network. Well, when we came out with our attitude on we're going to make all this work better, Cigna said, we're turning off the network. You can't do that with our network. We had a contract that they had to keep that going. United Healthcare bought the TPA for the sole purpose of shutting down Simplepay. Right. And can they do that? Absolutely they can. This is America. You can be mean. And so it just, that's what happened. And so you get, well, wow, the network is gone. Now the TPA is gone. So these were the same.
Where do you get the information to rank the doctor?
To
rank the doctor.
Where do you get the information? So there's several sources. The data I used here was not Simplepay. It's a different source, industry available, another company. Simplepay was getting that data from Compass. So they were using the Compass data in the navigation, and the company that Scott had owned there, that's where the data rankings were coming
Why
from.
would a doctor take a situation where he has a patient come in, it's a difficult surgery that may not go right? Why would he take that surgery if he wanted to be ranked high in your group?
So the question is, why would a doctor take a difficult patient that may not go well if they're thinking they may not get there? Every doctor, very common for doctors to say, my ranking's wrong because I have the sickest patients. We're not in the business of trying to figure that out. It's part of why, from a Holmes-Murphy perspective, we never want to be in the business of trying to measure physicians. I don't want us as a broker to be doing that. I want to use companies like Simplepay. I want to use companies like United Healthcare, Blue Cross, Cigna, Aetna. I want to use other entities that do that. I want to ask them a lot of questions about how they do that. But I, as a broker, don't want now, nor did I want when we were running Simplepay. I wanted somebody else doing that because of those very things of I don't want to be the one that's putting pressure on a doctor. I don't want to be the one making that. Our errors and omissions insurance as a broker could never cover if we as Holmes-Murphy told somebody where to go. Yours could be. What's that? Not on purpose. So it's so let me kind of wrap with this of what happened. So that put the whole business back on its heels. Had to start over in terms of this. That caused us to go at this with a level of humility that we didn't have when we went at it the first time. Big mistake on our part. And so the way we were positioning this was not received well, and it hurt the product, it hurt all of that. We went back to the drawing board. And it's really kind of the way that I look at everything. And I think Simplepay looks at it in a similar fashion. We don't have enough stroke anywhere to disrupt anything. None of us do. And we'll get run over if we try to disrupt. But can we creatively optimize and enable better performance out of existing structures? And that's, I think, our industry challenge. It's not to take on United Healthcare or take on Blue Cross or take on that. You won't win, we didn't win. That was never the point of what we were trying to do. We were trying to build this with and for them. When we repositioned with a better attitude in terms of what we were trying to accomplish, we secured a relationship with that to say, we can take your network and actually get a better result. We can make your program work better. Not replace, not fight against, not criticize. We can take your existing structures and extract a better patient and a better provider outcome out of that and a better financial result. Then that was ultimately what Blue Cross Blue Shield of Minnesota, after the the chief medical officer for Blue Cross Blue Shield of Texas sat in our office and yelled at me for 2 hours initially around all this. You know, a market where we weren't there actually got intrigued. Blue Cross started looking at this and thinking of the same way of really thinking about the challenges that they're trying to solve. How do we make it easier and more affordable for that patient to get to the best doctor? And when they started looking at it that way, then Blue Cross Blue Shield of Minnesota got intrigued, ultimately ended up buying that business. We as Holmes Murphy had to get out because it was limiting Simplepay when we owned it. Were other brokers going to implement this program? In some places and ways, yeah, they would look at it. They would really look at this as an infinite game. But others looked at it as a finite game and said, well, if Holmes Murphy is somewhere behind this, then that. So that's why we as a broker completely exited that business. Still think it's an awesome business. I miss working with Wally every day, but it was best for that business, and I think it's best for the industry. But that's kind of how we all have to be thinking, is what are the big challenges that we're facing? What are we trying to solve? And to me, and I think for all of us, it's how affordable is this? The percentage in the latest Commonwealth study, they are estimating that 26% of people who have employer-sponsored health insurance are underinsured. What that simply means is if they get sick, they can't afford it. That's 1/4 who have insurance. We need to be solving that creatively, whether it's with Simplepay or some other way. We need to be trying to figure out who has the quality data, and whether that's Blue Cross Blue Shield data, Aetna data, third-party data. How do we get people to the best doctors to get the better outcomes and solve some of that? How do we solve the T-Rex effect? So that's kind of my last. I think we're probably at time. Wally's probably going to close.
Let's make a closing comment. It'll build, and I know we're at time. You know, we really are looking at this as an infinite game. So whether it's Simplepay or any other option, we have a chance to use health insurance. This was one of our one of our taglines when Dan and I co-founded ACAP Health was, we will partner with others who will expand our influence so that we can extend the quantity and quality of people's lives. We're partnering with that. We're owned by one. And we are going to try to use insurance to extend the quantity and quality of people's lives. And we have enough data now, enough experience to see that we think we're on a right pathway, but it's going to take all of us working together to be courageous about what we understand, and then to actually help guide the industry towards those new opportunities. So thanks for
Question.
question.
One question. My
Yeah.
last question.
Just one.
Broker compensation. How does that work, and who gives it to the where?
So, This is think of it like you could buy an Aetna PPO, you can buy an Aetna high deductible health plan, you can buy an Aetna Simplepay plan. It's basically just the name of a plan design, and your insurance is going to work the same way from a funding and a network perspective. I will say we're initially starting on self-funded and level funded, and not yet available in. And then broker compensation will be built into those insurance premiums the way that it would be with any other insurance product.
In Texas, it's a Meritain program.
Yeah. Okay.
So I'll wrap up one thing. So again, back to the infinite game. Why do we need to solve these challenges? That we were perilously close to having President Bernie Sanders. And think back, it seems like, what? No, we weren't. He's the guy in the mittens. And so think back before Super Tuesday, what happened? Joe Biden was an afterthought. He was getting his butt kicked everywhere. He finished 4th in Iowa, right? He finished behind Elizabeth Warren. I mean, it was not doing well. He was not going to win the Democratic nomination. Bernie Sanders was positioned to win before Super Tuesday. Democratic Party convinced Mayor Pete, Amy Klobuchar, others all to pull out the week before, put their support behind Biden, consolidate everybody else to try to overcome Bernie Sanders. It worked. What was Bernie Sanders' one platform? Medicare was all he had. Right, and we haven't heard from him since his mitten episode, right? He's just gone into the closet. We haven't seen him. But those challenges, why did America get behind Bernie Sanders on this singular issue? Because they were frustrated with that which we had helped provide. We need to be part of that solution. We can't forget that we've got to make this work better. We all have to work together to do that. So that's my encouragement there. Yes?
Question. Is there like a maximum out of pocket for the year or each show?
It's a 3-tier copay plan up to an out-of-pocket maximum. It's going to be ACA compliant, and I didn't get into it, and it works on both a first dollar basis and a qualified high-deductible chest. So I probably, if you've got questions and you want like a full walkthrough of the model, I realize in doing it in pieces as we were trying to storytell that some of these parts may be a little fuzzy. Just, I'm sure my contact information would be available, or I'll give you my cell phone numbers, 214
Amen right now.
906-7686. 214-906-7686. Just text me and we'll connect together to walk through it. So thank you.
And I don't even have voicemail on my cell phone. Thank you very much.